we are going to start a very interesting course that is innovative methods to manage the complications, intraoperative complications. And we have very renowned speakers with us, Saurabh Patwardhan, Deepak Magyur, Kamal Kapoor, Rajendra Prasad, and myself, Dr. Satanshu Mathur, and Dr. Nivin. So there's a change in order because Dr. Saurabh has to go, and he will be speaking on jonular dialysis prevention and management. So he is a very good teacher. We have seen his videos on YouTube, and today he is going to demonstrate how to manage the jonular dialysis case. Kamal, tera next hai na? Rajendra? उधर बैठ जा.
पॉज वॉज आएगा करने. हाँ करो चलो करो. दिख रहा है वहाँ पे?
हाँ.
Good morning everyone, and thanks a lot Dr. Satanshu Mathur sir for inviting me in this particular IC, and I'll be speaking about subluxated cataract or zonular dialysis cases. Everyone, so all of us who are dealing with the cataracts, when we see a case like this, it's sometimes mouth watering. It's just like someone who is a hiker or climber. They look at Mount Everest and they say that I want to climb it once. So similarly, subluxated cataract is like kind of a last resort, like last challenge we want to conquer. So let's go through the thought process of how to conquer it. So we know that 360 degree there is a zonular attachment, and based on zonular weakness, it can be either static or progressive. So that we have to first understand. Accordingly, we have to plan it. So, or also it can be diffuse or it can be a localized zonular weakness. So based on these two things, we have to decide. For example, if it is a localized and if it is a static, it's very easy to fix the bag. But if it is diffuse and progressive, then we may have to fix the bag, as well as sometimes we might just have to remove the bag and fix the IOL directly. Okay, so the final decision depends on what kind of zonular dialysis or zonular weakness or the disease you are dealing with. Okay, so many times the problem happens when we are not sure what procedures we are going to follow. So if it is a small clockers like 3-4 clockers of it can be just treated by just CTR. But if it is more, say 6 clockers or more, then we have to either go with a Sioni ring, fix it with sclera, or we can use CTR, and then in that area we can put a CT segment, which is a easier approach than Sioni, and you can fix it with the sclera. Now when it is much more, for example 8 clockers or more than that, then sometimes only one side CTS is not sufficient, because then ultimately it might get decentered to the other side. So we might have to put 2 CT segments on at 0-180 degree apart. Now one of the important thing we must understand while dealing is the difference between iris retractors and capsular hooks. So what happens when we use iris hooks is that we are supporting only the anterior capsule or the capsular margin. The equator is not supported. So when you are operating, the equator or the peripheral back can still come up into your probe. When you use capsular hooks, because it has a long bulbous tip, it will support the equator, which is much safer in case of subluxated cataract. Now regarding use of the CTR, there are two schools of thought. First school of thought says that use CTR at the end. I generally go by this thought process. The reason is that you can just support the area of dialysis using capsular hooks. Because you are not put CTR, you are not committed to keep that bag. You don't have to fix that bag. You have an option of open that you can just fix the IOL, and it's very easy to remove the cortex. It doesn't get trapped under the CTR, and then at the end you can put the CTR depending on how the bag is doing at the end of the surgery, and then fix it to the sclera, or sometimes even just CTR is sufficient depending on how much the dialysis area is. The second school of thought says use the CTR at the beginning, but one thing we must understand, CTR just redistributes the support. It does not add support. So if the zonular dialysis is more, just putting CTR is not enough. You have to add capsular hooks to support the area of dialysis, then complete the surgery, remove the cortex, everything. But in this case, because you have now committed to keep the bag, make sure you don't have a PC rupture. Because if you have a PC rupture, you are in a dilemma that you have to just keep the CTR as it is and go for another. So keeping that CTR becomes a trouble. You can use any of these sutures. Generally nowadays we avoid using 9-0-proline, because after 8 to 10 years it has been seen that it degenerates. You can go for a 6-0-proline or Gore-Tex suture to fix it to the sclera. I generally nowadays use 6-0 proline and use the double flange technique, which is easier to fix it to the sclera. Now, there are many other options which will be available in future. So what you have to do is that stick to one particular technique when you are learning, and later you can explore the other options. So generally, when I started using 9-0 proline. Later I just fixed myself to 6-0 proline, and that I continuously use. Another important thing, how to insert the needle when you are fixing the back to the sclera. The first direction of the needle should be always 90° to the sclera, and then it should go parallel. So if you, because generally we are taught as an anterior segment surgeon to go always parallel to the iris. That is an intuition, But if you do that, you damage the iris root, or you go through the iris, and then it becomes a problem later on, because sometimes the iris or the pupil gets dragged to the side. And always also fill some OVD between the bag and the iris, so that there is enough space. Otherwise that needle itself might penetrate through the bag. So I'm going to show you a couple of cases of how it is managed. So this is a basically post-traumatic, you can see the zonular dialysis, and also you can see traumatic mydriasis, huge one. What is important is that when you do the capsulorhexis, keep enough area of anterior capsule in the area of dialysis, which is important, because if it is too close to the margin, the game is lost, because then you cannot support that area using the capsular hook. So always keep in mind, even if you have small capsulorhexis, that is fine, but there should be enough. Now avoid complete hydrodis. That means you should not prolapse out the nucleus, because sometimes the bag then starts dangling and it's difficult to put the CTR. Now you can see I have put the capsular hooks in area of dialysis, supporting it. And remember, once you have these capsule hooks, it is like a usual normal surgery, because now these are working as your artificial zonules, and these are much stronger than your natural zonules. So just go ahead with the regular phaco. Only thing you have to mind is that there is a high chance of fluid going behind, because that is the area of zonular weakness. So sometimes PC might start coming up at the end of the surgery. For such cases, just stop before you, for the last piece, put more OVD, okay, reduce all parameters. You can do little anterior phaco, so you avoid the PC rupture. Okay, that is something you have to always keep in mind. Then you put the CTR. Okay, once the nucleus and cortex, you have removed everything, then you put the CTR. Now you remove the capsule hooks. You judge how the bag is behaving. Now in this case, you can see the bag is still decentered. So I place the IOL in the bag first, and now I plan to fix it using CT segment. So first thing you have to do, here I am using, I think 6-0 proline there. So first the CT segment has gone into the bag. Here I am using 9-0 proline. So this is, very simple railroading technique which you can use to fix this, and don't overstretch this, okay. And at the end I have also done the pupilloplasty, so I brought down the pupil. Now this is much commoner case which you, face during surgery, because if you already know that there is a subluxation, you are better prepared to manage that case. But this is more often you see in practice, because you have seen this patient pre-operatively, but you have not judged how much the zonular dialysis is. So here you can see it is a diffuse zonular weakness, which you typically see that there is wrinkling of the anti-capsule when you start the capsulorhexis. So in such cases, how should manage? And this is also brown, or these many cases, they have very hard cataract. So in this case, I will go with CTR first approach, because I want to support the back completely using the CTR. But again, you have to always keep in mind that this is just redistribution of the zonular strength. It is not adding any strength to the back. So always make sure. Now you can see when I started rotating, there was a lot of movement of the back. So I know that this is going to require further support. So first I did is I cracked the nucleus completely. I am trying to do bimanual rotation here, which is very important. If you saw that, okay, many times what you do is that you continue to do the same, unimanual rotation which you normally do. But what happens is that whenever you do unimanual rotation, you are basically taking support of all the zonules which are there, because that is the one which is holding the bag and you are rotating. But if you do that in a zonular weakness case, it is going to break a lot of zonules there. Okay, so you should always do bimanual rotation in these cases. So that's what I did, and then I chopped it further. But once I chopped, I realized that zonular weakness is really, bad. So what should you do in such cases? So, the thought process should always be, is the zonular support enough for me to proceed or not? Okay, that is something you should keep in mind. Now in such cases, how you can support the bag? You can use either capsular hooks, or in this case, I am using the iris hooks to the anterior capsule. Okay, I am supporting the anterior capsule with the iris. Why? Because the pupil is also going down, so I am using iris hooks. So now you can see the rotation becomes much easier, because now the bag is supported, so it has a counter traction. the nucleus is now further emulsified. So during process, you should always keep in mind whatever I am doing, is it putting extra stress on the bag? Is the bag well supported? Many times when you don't look at that when you are beginning the surgery, it ultimately results in further damage to the zonules, which are already little bit weak. So now after completing it, what I have done is that I have removed the iris hooks from the capsular margin to the iris, because now I want to look at the bag, and now I am doing the standard IOL trap technique. This works beautifully in these cases with kind of a diffuse zonular weakness in case of PXF, and these IOLs are very stable. They have very minimal or no pseudo-phacodonesis as compared to if you put the IOL directly into the bag, and it has worked wonders. So whenever you see such case in your operative, because these are the cases you will find more often on your operating table, which you have not diagnosed or which has been missed during the surgery. So thank you so much for
Thank you,
this
Saurabh. Thank
opportunity,
you.
Dr. Satanshu.
Thank you. Rajendra, any comment? Kamal, you can start. Dr. Kamal Kapoor is from Delhi. He has sharp side centers. He has many centers in India. He is going to import a very important topic, that is capsular axis if it goes wrong. Rajendra, one comment if you have any.
Very nicely presented, and the beautiful technique. He's always there for any problem, and we also learn a lot from his videos, and really beautiful videos. Thank you very much.
Thank you, Saurabh. Thank you. Well demonstrated. Thank you.
Very well demonstrated, Saurabh. Only two small points I'd like to put on. If your zonules are weak, expect a floppy posterior capsule also. It is going to come up and flutter. So, because when your zonules are gone, zonules have an equatorial, anterior and a posterior tag, which keeps the capsule stretched. So if you've lost a particular part of zonules, even the posterior capsule doesn't have a support. So especially when you take out the last fragment, this is the time when your PC will start fluttering. Second small tip is when you inject the viscoelastic in the bag, not in the anterior chamber. If you put in the anterior chamber, it will break your vitreous phase and go behind, and then you are in trouble. So always, the trick I use is I use a 27 gauge cannula and go in the bag into the rexes with the needle pointing downwards into the bag. So as you expand the bag takes a shape. So just like Saurabh, you can actually go to my YouTube channel, Ophtha Gurus, and you'll see most of the videos you see are there too. So okay. So I'll be talking about capsule rexes run out. Before that, we'll try and understand what are the tantrums what the anterior capsule can play. Most of us are talking about posterior capsule zonules. The poor anterior capsule is often ignored because we take it for granted. Rexes hai to ho hi jayega. But what happens when rexes goes wrong? So let's see some helpful tips. So what are the situations you can have? You could have a peripheral run out. You could have your keratome, which suddenly patient moves, you cut the capsule. You have a peripheral run out with a large tag. You have a peripheral run out which has gone through the posterior equator and cut your posterior capsule. And you could have a femto surgery done where your tag is getting extended and then you're stuck up. Or you could have the most feared Argentinian flag sign. Now we will talk about all these situations as we move along. So there are some basic principles. The capsule is thickest in the mid part, which is between 5 to 7.2 millimeters. That's where zonules are inserted. So try and keep your rexes within this zone, because this is the area where you have a lot of control. The moment that capsule rexes runs out of this, it touches a zonule. And zonule is like a rope. It starts pulling the rexes outwards. So there is a play of centrifugal and centripetal forces. It's just like a trampoline which is stretched. So the safe zone as a rexes is 5 to 6.5 millimeters. So to have a stable rexes, you have to have a good anterior chamber pressure, which has to be higher than the lenticular pressure and the vitreous pressure. As long as you have that and have your anterior capsule flattened, it's not going anywhere. But the moment the anterior capsule starts tenting, this is when the zonules start pulling it out. So when you have pushed the anterior capsule down, the anterior zonules are relaxed. But the moment the anterior capsule stretches like this, the anterior zonules are stretched, they start pulling your rexes out. So you have to make sure. So there is a play of centrifugal and the centripetal forces. Your centripetal forces are higher when the capsule is flat. Your centrifugal forces are higher when the capsule is rising up. When does that happen? You have a leaky wound. You have less viscoelastic. You have air bubble trapped into the anterior chamber and suddenly the air bubble leaks. So these are the situations where you can actually get caught. So we need to maintain the centripetal and the centrifugal force barrier. So you can have a leak of visco, hypermature cataracts. Again, there is an increased intralenticular pressure of the capsule. This can lead to this tearing away. So let's understand this. So as your needle is pulling it, there is a leak of viscoelastic. The vitreous starts pushing the lenticular diaphragm upwards, and this starts pulling the zonules out. So that is how you have a peripheral runout. And this is a situation. Now, in case you have a peripheral runout, this is called Little's maneuver. I'm sure all of you know that. There is a peripheral runout. The pupil is not very well dilated. You need to break this with a jerk. You'll see. Go as near to the tearing edge, one jerk, break it. If you hesitate, it is gone. So you go 2 trips. Go as near to the tearing model, radial and tangential, in one go. So you can save the situation like this. Now this is a case managed by one of my juniors. You'll see what is happening. It's a mismanaged peripheral extension. There is so much of pulling, pushing. So in the end, I was called to manage. See what is happening. The person is just pulling, tagging, stretching, because they can't find the capsular edge. And the more you disturb the anterior cortex, more you lose the capsule site. So the trick is don't fiddle with the anterior cortical fibers, because then you lose the site of your anterior capsule. Now see what has happened. So I've been called, I finished the case, and see, there is a complete tear. You will notice. Can you see the capsule tag there? There's a complete tear through the equator. But luckily the anterior vitreous face is not. Now you can see the tear. But luckily I managed not to break the anterior face, so we went ahead and put the... Now this is the technique again which has been described by me. I call it the inverted T technique. Very simple in intumescent cataracts. You push in viscoelastic, take a 26 gauge needle, bend it by 70 degrees, bevel downwards, have half cc water into the syringe because water is non-expansile. In one jerk, puncture the 1/3 outer inner 2/3 junction, and with one jerk start aspirating the fluid. You'll notice I've reduced the interlenticular pressure, and as I do it, then I just dip the cataract nucleus down so there's more fluid from behind which has come up. Now you push in viscoelastic, flatten, enlarge the wound again. Now initial wound is small because I don't want the visco to leak. Now I enlarge the wound. Now you just take a 1 hour and create a T. You'll see we create a beautiful T, and now this T has 2 flaps. Now I have 2 options of making the size of the rhexis, site of the rhexis, shape of the rhexis. Now you have a T, you can use a needle, you can use a forceps. Again, now I instill some viscoelastic because I want to lift the flap. Now flatten the anterior capsule again, use the forceps. Now you can rotate it completely or rotate it half and then complete it by the other half. I'll just fast forward it because there are around 28 videos which I need to show you. So this, and then the other edge is taken in, and you are safe. So 100% of cases of intumescent cataracts you can solve like this. Now this is a fibrotic cataract with subluxation. Now you see, notice there's a zonular break, posterior sine cave, fibrotic thick capsule. Now I'm trying to cut it with the needle is not going to cut it. The needle is not able to penetrate it. So I'm just cutting the interior fibrotic part of the capsule. I've not cut the capsule. See how tough the capsule is. So I finally use an MVR. Again, it's not cutting. And yet there is a lot of subluxation also. So I don't want to do a lot of maneuvers, otherwise I'll have vitreous come into the anterior chamber. Now I'm using a curved vanas. Still not working. So I'm using vanas, needles, keratome, curved scissors, everything to complete. You see, in the end, it's over. The capsule has been cut. See, now the beauty is I've got a rhexis, I've taken the cataract out, but there is so much of fibrotic anterior capsule. This is going to be unsightly for the patient. So I put in the CTR, and after that, I use a cutter now to nibble the rim so that I have at least a cosmetically clear area. Otherwise, when this pupil will dilate, you'll see a white ring here. So I use a cutter to complete this particular procedure, and this surgery is over. Now this is another interesting use of inverted T. The moment it starts running out, I switch to inverted T. This is one of my earlier videos. Now you see, I can feel it's going to run out now. So what do? I stop, I push in viscoelastic. Once I push in viscoelastic, I go within this cut with a bent 26 gauge needle, aspirate this fluid from under the capsule, reduce the pressure, flatten the anterior capsule. I'll just fast forward it so that we can see what I'm doing. See, there I've created a T there, sucked out all the intralenticular rising parts. You see the capsule has suddenly gone flat, the pressure is reduced. Now I go in that area where it is extending, suck out the cortical liquefied matter, and now again convert the inverted T and convert it and finish it, so that I don't have a peripheral runout. Now this is once an Argentinian flag sign has happened. Now what do? Stop fiddling. Make the anterior chamber pressure high, but do not make it too high, because a very high pressure also will extend the rexus. The end sign is your capsule should just get flattened and the iris should just start going back. That is the end point. Now again I'm using the T technique to reduce the pressure there. You will notice I've aspirated, or there you see the pressure has gone down. Now I'm in a safe zone. Now this is not going anywhere. So again, use the same thing, cut it, 2 flaps, rotate it, finish it off, and then unknock, and there you go. Tell me, Shannu, when you want me to stop.
Yeah.
Tell me when you want me to stop.
One more video, show, and then.
Okay. Now this is interesting. Sometimes you're doing a rexis and the tail, you so get engrossed, your rexis is long and you have a tail which starts coming out of the main wound. Be cautious. This tail will rip your capsule rexis. It's because every time you go in, the viscoelastic comes out. And if this tail gets caught into your wound with the viscoelastic, it will come out. So see what happens. I have a long tail. I purposely recorded to record this video. I created a long tail because sometimes you can land up with a tail like this. So see what happens. This tail is trying to come out of the wound. Now it's stuck in the wound. Now if you push in viscoelastic and don't cut the tail, see, the tail wants to come out. See, if you don't stop here, you have a peripheral runout. So the trick here is go in, pull the tail in from the side port. Don't push it in from this place, because the moment you push in, visco will pull it out. Pull it in, nip it, complete the rexis, and then you are in business.
Okay. Thank you, Kamal. Thank you, Kamal. Nice demonstration of different problems on the left axis. This is this T, making the T in the intubation cataract is a very good technique. We have also started using it. It helps very much because we can make capsulation for both the sides and it completes the CCC. So thank you, Kamal, as always. Now I invite Dr. Rajendra Prasad, a very versatile, many innovations in the name. He will be speaking on how to manage the hard cataract by his innovative method. By his innovative method, and he has got a special chopper for it. And this is technique we can use, especially not in the heart, but in each and every case. We welcome Dr. Nivin. He is from Chennai. He has developed a new IOL for circle fixated IOLs that he is going to show very recently. Any question on capsular axis till we start?
Good morning, everyone, and thank you, Dr. Satanshu, for keeping me in this wonderful IC. The topic which I am going to talk about is while chopping, when the cataract doesn't crack, how to manage it. You know, these hard cataracts have a series of specific and difficult challenges. These cataracts have a very dense nucleus, very large nucleus. The capsule is very weak, zonules are weak. There is no buffer behind the nucleus. Nucleus is essentially sitting on that weak capsule. And at the same time, the nucleus doesn't crack many times, whatever you do. And then what happens? You are left with these unsegmented nucleus, and you tend to do a lot of manipulation inside, try to hold it, push it, pull it, and many times you land up with many of complications. The complication could be because of a high CDE value, so you tend to damage the endothelium. Shear rupture forces, because you are pulling and pushing. You may have a PCR, you may get into the zonular dehiscence, and many times nuclear drop. You know that the chopping techniques utilizes purely manual mechanical instrument forces to fracture the nucleus. And nuclear fractures would depend on the kind of chopper you use during the chopping and the geometry of the vector forces you're using to chop the nucleus. It is the position of your chopper and the position of your phaco probe which is going to decide that whether this nucleus is going to crack or not. So fracture failure may happen improper selection of the chopper. If your position of the chopper is not correct, it's too superficial, asymmetric, it's misaligned, or you're too much lifting the chopper up. So these problems could lead non-fracturing of the nucleus. So what you need to do is, there are several choppers available in the market. So you need to select according to your technique, the proper chopper. What I suggest is this is a specialized chopper. This is very efficient to generate the tensile fracture force in the nucleus to break the nucleus. See the shape of the chopper. This is a wedge chopper. It has a ball-shaped tip. It's a round tip. It's not a sharp tip chopper, but its inner edge is sharp. The inner edge is a wedge shaped. It's a triangular wedge shape. And this wedge actually creates a tensile fracture force. So you don't have to cut the nucleus, you don't have to compress the nucleus. It just gives a tensile fracture force and the nucleus cracks into two complete segments. You have to very simply split it with minimal forces and you get a complete cracking, and you get a cracking in a full thickness of the nucleus. And full thickness, that is very important because many times when you are cracking this hard cataract, you are left with a thick posterior plate, and that posterior plate is the problem. Then drawing and fracturing that posterior plate becomes so difficult. But if you get a fracture of the posterior plate also along with the whole nucleus component, then you don't have to trouble because you get a complete two segments of the nucleus. And if you get a two segments, then you can make a multiple segments, and then you can simply draw these free segments on your phaco probe and start emulsification. So to start with, you have to do a good preoperative examination. Your pupil has to be well dilated. If not, then you can put the rings or hooks. Your capsulorhexis is very important because always stain the capsule whenever you're dealing with the hard cataract. Do a good large capsulorhexis, at least 5.5 millimeter minimum to 6 millimeter. So do a good capsulorhexis. Make sure that your nucleus is free within the back. So do a good and minimal hydrodissection, hydrodelineation if possible, and try to rotate the nucleus. Rotate the nucleus before you start the chopping because you have to have a free nucleus within the capsular bag. And then the tip of the phaco probe have to be exposed at least 2 millimeter minimum because you have to penetrate the nucleus well into the deep nucleus, or maybe in a horizontally a little larger depth. So you can see here, because I'm penetrating the nucleus to deep and towards the equator, not at the center, hook it and crack it. And then see the crack, so you get a complete full thickness crack. And with a very minimal force. See here, because the force is being generated by the chopper, you don't have to put too much of job. Because you know that these wedge choppers, it changes the radial force into the transversal force. So you get a good fracture of the nucleus, and these free segments, once you have these free segments, you can very easily draw them and emulsify with a minimal phaco energy and minimal manipulation. This is another case, a hard nucleus, maybe around grade 5, 6 nucleus, brown nucleus. You see, because you have to just penetrate it from the center, go towards the equator, don't go towards the posterior capsule. You have to go a little horizontally towards the equator, hold it here well, you have to have a good vacuum, hook it and crack it. See the cracking? Now this is how you get, and with a very minimal splitting force, you get a full thickness crack of the nucleus. Crack the nucleus into multiple fragments, 2, 3, 4 segments, as you are comfortable in cracking these nuclei. Because smaller the fragments, it would be easier to emulsify these fragments with the phacoemulsification process and during the emulsification process. So this is how. Many times you have a leathery nucleus. So in leathery nucleus, you have a fibers attached. So these fibers have to be separated very well before you start drawing them. Don't draw the nucleus fragments unless you are sure that the nucleus fragment is free. If you try to draw the unsegmented nucleus, then you will be putting a lot of stretch on the zonules and you will land up with this zonular dialysis and dehiscence, so which will complicate your surgical procedure throughout during the implantation of the IOL also. I'll show you a few more cases, and this another case. You have to just look at the position of the phacoprobe and the chopper has to be parallel to the phacoprobe, exactly opposite the tip of the phacoprobe. If the chopper is right and left, your nucleus will start rotating, you will not get the chop. It has to be exactly opposite to the tip of the phacoprobe. And phacoprobe should not go deep into the center of the nucleus. It has to travel from the center towards the equator, and then you will get it. It's a length should be good. A long length of the phacoprobe would give you a better hold of the nucleus. This is, you can see another case, grade 6 nucleus. Normally we can't think of doing this phaco with this. You'll definitely go in for the MICS or ECC, but you can see here with this chopper, you can crack even these kind of the nuclei also. See the fragmentation of this nucleus. A sharp fragment and hold the nucleus, that's the next heminuclei, fragment. See the division of the nucleus, the kind of division you get, and then you can draw these hard segments with the phacoprobe. Use energy after you hold the nuclear piece. Don't start pressing the foot paddle initially, because just first hold the nucleus piece and then press to induce the energy for emulsification. And once you complete the emulsification, you can see the next fragment is left. You just hold it. Now look at the tip of the phacoprobe, the position of the phacoprobe. It's not going posteriorly, it's going horizontally towards the equator. Crack it and then finish it. So I'll just finish it here. And this is, I'll just show you a few diagrammatic representation. The position of the phacoprobe is this. It's not, see, in horizontal chop, you go deep. Here, you're not going towards the posterior capsule. It's going from the center towards the equator. This is one thing. Then you have to slightly tilt or draw the nucleus and then hook it. The hooking has to be complete. You have to hook completely. So that your posterior plate is included in your hook, and then only you'll get the complete crack of the nucleus. This is how you get the crack. So to conclude, whenever you're dealing with the rock-hard cataract, your surgical technique and the technology should aim so that you are generating least energy in the anterior chamber with a minimal manipulation and minimal strain of the zonules. Keep it in mind, zonules are very important in these hard cataract, and while protecting your corneal endothelium and the capsular bag. Thank you very much.
Thank you, Rajendra. So this is a technique that he is using, and we are also using this technique, especially in hard cataract is really very useful, but it is sometimes very difficult to reach to the equator area. So you should be very careful when starting it. My friend from Italy, Dr. Rosanatelli, is using it. He is using not the chopper, but his simple instrument which has a blunt tip and they hold it. So there is no chance of damage of the posterior capsule. But he's a master, he can do it. But initially what we should try not the very hard cataract, but in the medium hard cataracts. Once we had the confidence of going behind the equator with the chopper, then we can proceed with the hard chopper.
Yeah, you can start with the grade 2, grade 3 nucleus initially, because you practice on grade 2 and grade 3. Don't go for the grade 5, 6 initially. You just practice, and it doesn't take much time. 4 or 5 cases, you will learn it. It's very simple. It's much simpler than the vertical chop and the horizontal chop. Much, much simpler. Terminal chop is very simple, but you have to just take few cases and see my videos. You'll learn it very easily. There is no problem. And I'm 100% sure, like 100% cracking of the nucleus you will get, any kind of cataract.
Okay, just 2 points here. I think that's why he's called the master terminator. So he coined the term terminal chop. Few things for the beginners. Whenever you have a big brown cataract, make sure your bag is going to be floppy, because this capsule, cataract is very thick, nucleus is thick, so it stretches the capsular bag. So coming back to the same point, you have a floppy bag, you have a loose bag syndrome. Number 2, zonules in these brown cataracts are very brittle and can be broken very easily. because especially with the large volume of nucleus, if you're trying to pull it out of the small rexes, that itself will break those venules. And fourth most important part, when you're eating into this cataract, you're so focused on to eating the nucleus, you forget the poor wound. You will have a wound burn. So you need to have good settings on your machine, which is pulse phaco, ice phaco, whatever, or continue to move your phaco tip within the wound. Do not keep doing phaco at the same point, because then managing a wound burn is another headache you will have. Thank you.
Thank you.
Thank you.
So that is our master terminator, India's Arnold Schwarzenegger. And the next person is India's James Bond, Dr. Nivian Madhivanan, who shall be talking to us about his latest gadget, the CMT Flex, probably in the PCR management. All is not lost. Welcome, Dr. Nivian.
Thank you, Saji sir.
PCR is the normal complication which can happen in any OT with anyone. So most important thing that we should not create a havoc in the OT so that the patient and staff all are anxious. Keep your calm and try to manage the PCR. It is very easy. He will show it. He is a posterior segment, but even the anti-segment surgeon, every surgeon should learn the anti-vitrectomy. Every phaco machine has the anti-vitrectomy concept. We all should learn the anti-vitrectomy. It is very simple. Few steps has to be taken. Never go from the main wound, make the side ports and do the anti-vitrectomy from side ports. Start from the dry anti-vitrectomy, then go for the... So these simple points are there. If you follow, any anti-segment surgeon can do the anti-vitrectomy. And if there is any, and you can implant even in the bag implant, if you have well managed, you have this PCR. Sulca fixated IOL, they are another option we have done, but we should never get afraid of this PCR. Vitrectomy should be ready in every OT.
This is available with Epsilon.
Dr. Deepak
Epsilon.
Megur, can you please come to the front row?
Deepak here.
Oh, he's here.
Can we
क्या प्रॉब्लम आ रही है तुम्हारी?
Mr. James Bond has problems with his gadgets? That's surprising.
I have it loaded in both the places. So thank you once again, respected teachers, senior ophthalmologists, my dear friends. So I'm going to talk about the PCR management, as Santanshu sir has already hit all the take-home points bang on. So just wanted to start off with the ritual question, like as we see a packed house here, like how many of you have had a PCR here? Can you raise your hands? See, that's nice. So now more and more as I keep doing it every year, I see more hands raised, because initially we were scared to accept that we have a PCR. So that is the first thing. The second question I had to modify it a little bit. How many of you manage your own PCRs? See, that's why these courses are
That is the
important,
problem.
because
That is the
Nivian,
problem.
it's only outstanding surgeons who don't have PCR, and these surgeons are standing outside the theatre.
No, but I'm happy to see most of them are managing their own PCR. So the whole aim of this thing is, like, when you go back, you should be able to manage your own PCR cases. So what differentiates between a good and becoming a great surgeon is how you manage your PCR, and you can still give the results. So I basically work on the principle of, and that have no fear of the vitreous. So it is how you tackle it and manage is what is going to define your surgical outcome. So let us go to the gold standard video that I followed. So you can see this is an old video. So usually when we have always heard, no, that the PCR happens during the last stage, and you can see there, because of the older machines having surge. So the first thing that they thought is recognition. So you accept that there's been a PCR now, and then start slowing down things. Even though you have a small piece left, try to bring it away from the area where the rupture has happened. You see everything is slow. So now you have time. So you're doing a slow phacoemulsification and not moving around too much into the anterior chamber. So the second step they always tell is make sure you fill the anterior chamber with viscoelastic. Yes, if you do a high density viscoelastic, it plugs that hole. The same way, you don't let the anterior chamber to collapse when you bring out. So the concept is, sometimes the anterior hyaloid doesn't rupture. It is only when you come out it flattens, then only the anterior hyaloid ruptures and you see the vitreous prolapse. So there is a rupture, but it doesn't mean that all cases will have a vitreous prolapse. So as long as you can maintain the anterior chamber and come out, you still have some amount of safety margin and less amount of vitreous. I always prefer the bimanual for two reasons, because you separate the irrigation and the aspiration. So sometimes you can point this away from the area of the rupture. So what happens if more and more liquid goes, that can hydrate the vitreous and prolapse. So what basically I'm trying to say, what all you can do to minimize your extension of the rexus and to have a good outcome. As sir already said, all machines have anti-vitrectomy. It is just that you should know your cutter, your settings, and keep it ready all the time, because you don't know which 1 in 100 cases you might have it. So this is just to show how the anti-vitrectomy is done. I always prefer to stain, because even though it looked now nice round people like what we have thought, but once you stain, you can see that vitreous blocked there. So you can use irrigation in one hand attached to the cannula, or you can use your bimanual irrigation also, and you see the other side port, you use the cutter. So the trick here is just stay in the center. See, most of the times after doing phaco, we tend to move our hand too much. So in vitrectomy, it doesn't work like that, as it cuts and aspirate. As long as the vitrectomy cutter stays in the center, there will be good vitrectomy done, and as long as you clear the center, that is enough. You don't have to go deeper under the iris, because it is so fast. As we go near the iris, it just cuts it in a fraction of a second. So the trick here is to just stay in the center and make sure there are no vitreous in the wounds, and then you have a good thing. In this particular case, we did the iris claw lenses. So moving on to the other scenarios of what all you can use. Yeah, in certain situation, we can use the IOL scaffold. So you can see here, this is a mature cataract, white, soft mature cataract. So everything was going on well, can you see? And then suddenly you see the PC opened. So sometimes having a recording system to go back and see what happens. See, I was just seeing my phaco probe is here, my chop there, but then it opens up. Yes, sometimes when you have a high bottle height or a weak bag, it can do. But this particular case, I said this was a soft mature cataract, so it didn't sink in immediately. So in this particular case, I'm using the scaffold technique. See, basically again what happens is, you're just putting the IOL either in the sulcus or in the above the iris, making sure the nucleus piece doesn't go back inside, because once it goes, then it is a VR segment surgeon's perspective, isn't it? So as long as you can hack as a scaffold, make sure you maneuver this nucleus pieces. Here again, then reduce the bottle height, because sometimes you go with the full bottle height, the entire lens can also sink in because of overfilling the antechamber. So just reduce everything, again slow motion phaco, remove the nucleus piece, but you see the lens was decentered. So there is always vitreous there. So next is the pars plana approach. So slowly now we are shifting to the pars plana approach. So what are the advantages of using the trocar and the pars plana approach is, sometimes that vitreous block that you can see peeking out, no? When you do the pars plana approach, it actually gets sucked inside. So usually pars plana approach is much safer, it is actually easier, and it is faster. You can see that block that actually comes. So sometimes we ask, when you're doing anterior, when do we stop? Because as you do from the anterior segment, more and more vitreous tends to come. But pars plana approach, I think you exactly cut at the base and you make sure you know. You see, this is another case of SICS where there's been a large rupture. So as I said, always I prefer to stain. So once I stain, I wash it away. So I don't go by dilution, I just wash it. I put it in the anterior chamber, not into the vitreous. So you can see now only the strand is remaining. So you exactly know what you're going in for and what you're cutting also. So that's what I said, because there are studies that says when you do the pars plana, your vitrectomy time is shorter, it is safer, and that's all vitreous you have to cut. You don't have to cut more than that. And then in this particular case, the entire rim was there. So just going back and rechecking. So in first case, you have a claw as an option. As far as you have the rim, because it was a small incision case, we kept a rigid lens in the sulcus. Or if it is a phaco case, you can keep a 3-piece lens. So other thing in PCR management, make sure in your OT you always have the backup lenses. So we always have rigid lenses, 3-piece lenses and claw lenses, because you don't ever know when you're going to use them. So why pars plana vitrectomy again is, this is a small video that I got from my friend Dr. Samresh from Raghudeep. So this is the block that you're pulling the vitreous, no? So sometimes you can expand the PC rupture. So but same way when you're doing the pars plana approach, you're actually pulling the vitreous back inside. So that way it is actually safer and less amount of vitreous to cut, as you can see here, the vitreous strands that are prolapsing. And sometimes when you cut that, the things that are coming through the side port also just comes away. So you can just clear the vitreous in the side port also. So moving on to the next case, this was a case, again a soft cataract which was planned for a multifocal lens. Everything was going on well, but then again you can see there's a small opening. In this particular case, it actually happened during dialings, when we went back and saw the video of exactly when it happened. So again the same principles, make sure you remove the last piece and then put in viscoelastics before you come out. And the other thing is, always practice with your left hand, because sometimes it is not easy to inject visco when you're having this rupture with the left hand. So in your normal cases, try to practice using the left hand. The third thing is here, if you see, I always attack the cortex in the opposite side of where the rupture has happened. So I want to minimize the amount of problems that I have when the vitreous is there. So I finished the other half where the vitreous cortex was able to aspirate. But this side where the vitreous is, you can see there's a vitreous strand that is getting caught. So in that case, don't aspirate more. because you will not be able to remove the cortex. So here again, why the pars plana approach is, here you can use the trocar, and irrigation you can keep it in the anterior chamber and use the posterior thing only for cutting the vitreous, as you can see here.
You can use the regular phaco machine for this vitrectomy, or?
Yeah, that's why Santosh sir had so many wet labs, no? So nowadays there are so many nice wet labs to learn how to use a trocar, because most surgeons are giving intravitreal injections. So the concept, the place 2.5 or 3 millimeters from the limbus is all the same. It is just that I have had an instance with my friend where he had the 23 gauge trocars, but most of the anterior segment machines had 20 gauge cutters. So it doesn't go inside. So all these things you should be prepared before. See, in this particular case, because it was multifocal, what we could do is we could save the posterior capsular margin. So we could see the extent. So that is why, and I didn't have a 3-piece multifocal choice. So I had to place this multifocal lens into the bag. So here again, making sure that the leading haptics goes into the bag. And then slowly nudging, not dialing like how I used to usually do, just nudge it there. And then you see the lens is stable. You can see the Purkinje image. So I use the same trocar to even wash away the visco. And again, I don't go bimanual. I just use a Simcoe because I don't want to overfill the anterior chamber. And this is how the patient looked. Post-operatively, you can see a well-defined posterior capsular tear margin, but at the same time, a very well-centered IOL. And since this patient was happy, only he came for the other eye. This was the other eye, but he was actually happy with the eye which had the rupture actually. So why a good vitrectomy? Because we cannot hide it, because in a post-op period, you are going to someday find out you will have these types of vitreomacular tractions and forming ERMs very early. We all know that the chance of endophthalmitis is almost 5 times more if you have vitreous in the wound. And sometimes when the lens is decentered, they complain of this glare and this edge effect. So good vitrectomy is always a key. The only time I say don't do a vitrectomy is when you do these hydros and you see the entire nucleus gone inside. So at least that time, that is the only time I tell avoid doing anything else. Just make sure you have a good VR colleague. And if you don't believe whatever I said so far, prayers do help when you go into the OT theater. So this is one of the incidences where the last piece you can see here, that ECG is the ECG of the surgeon. You can see the entire posterior capsule is caught in the phaco probe. And the heart goes into the atrial flutter, as you can see here. But there's a reflex button in the foot pedal. If you hit the back side, there's a reflex button actually that's there, and then it is released. So I put in viscoelastic, I deepen the chamber nicely, and then there's the last piece. So I go in again with the phaco. See, it's nicely deepened. So now you see the entire piece, along with the whole capsule, is again got caught in the phaco probe. The whole thing is tenting up. As I think Kamal said, if you have weak zonules. But here again, after hitting the reflex, again there was no rupture. So this happens, this is your lucky day. So thank you once again, Santosh sir, for having me in this course. It's brilliant, a brilliant learning course. I think we've been doing it for more than 7 years now consistently. Thank you.
The most important thing, the anterior segment surgeon should have not have a thought block of doing the vitrectomy, anti-vitrectomy. 100% you can do anti-vitrectomy. We are teaching in the SSCC for the last 12 years. And many anterior segment surgeons have now started doing anti-vitrectomy after learning from the SSCC. Important 2-3 points: never use the main port, make the side ports, do the injector, do the dry vitrectomy initially, then do vitrectomy. Don't go much behind the posterior capsule, at the level of the posterior capsule, clean it. And if there is no, after time so long there is no vitreous, then you can put that lens either in the bag or in the sulcus, depending upon the PCR. If it is too big, then you can just stitch the wound and send it to for the vitreoretinal surgeon. Do not try to do much handling inside the eye if you do not have the good vitrectomy machine. Means the vitrectomy machine, 7,000 cutter is enough that you are having in phaco machines. Now we have important speaker with us.
Inputs from Dr. Kamal.
Yeah, okay.
And
I think
Kamal.
beautifully shown by Dr. Nivian. But you know, he's an expert. So my tip for the youngsters is suture your main wound when you do the vitrectomy.
Good.
Just remember this small tip. It will save you so much of headache, because sometimes when you, especially for a beginner, you don't know how to titrate the inflow, and you will start pushing vitreous out from the main wound. You will start having an iris prolapse and pigment and all that stuff. Sometimes you may even land up with an iridodialysis. So suture the wound before you start doing your vitrectomy. Always.
Another observation, please understand that the posterior capsule, the anterior hyaloid face, and the vitreous are 3 different characteristic
Absolutely.
elements with their own behavior, propensity, and temperament. Like in this case which he showed, the PC came to the probe yet did not rupture. There are PCs which are waiting to rupture even if you inject Visco. And then, after the PC rupture, the anterior hyaloid face in some patients is so cooperative that it ignores the PC rupture and allows you to complete the surgery.
Absolutely.
And then, sometimes the anterior hyaloid face can break and still keep quiet in its own area. Therefore, please understand that the PC, the anterior hyaloid face, and the vitreous are three different individuals inhabiting the same geographical location. Doctor,
Thank you. So now we have Deepak Magur with us. We have all seen his videos and demonstrations. And very important topic again during the surgery, because this IC course is only for the management of the complications in during surgery. So it is IFSI, intraoperative floppy iris syndrome. That is very common, and it can be managed how we can see.
So thank you for the opportunity. Can I have my film on the thing? Okay, fine. Thank you, Dr. Mathur, for this opportunity. The Indian brown iris, thankfully, don't behave so badly as we are aware that is made up of. It compared to the Caucasian, the thin iris. So we are lucky that our iris are still sturdy enough, but still they do cause some issues, and we need to address them and try to manage them when they happen intraoperatively. The problem is we don't know how they present. The case will begin like this, perfectly all right. You do hydrodissection, and then suddenly it starts to happen. This is how typically it happens. Then you go in and ask, are you taking tamsulosin? Are you taking all this? This all starts after the iris starts coming out. Then you know it's coming out. This is how its situation starts usually. Because now the problem is, it is not just the tamsulosin. Many drugs are involved with this. Many antihypertensive drugs are there. So it's become more difficult for us to preoperatively anticipate that which patient is likely to develop IFIS. So if you know that, if you're aware that this patient is on tamsulosin, then Dr. Sam Maskett proposed this theory many years back. Now using atropine 2 times daily, 3 days before the surgery definitely helps to maintain the tone of the iris much better. So if you are really aware of all these things, then you can always start this thing. Most importantly, there is no point in stopping any of the medications like, tamsulosin or something. It doesn't really help. So most common cause is, can we stop Urimax? Can we stop tam? It doesn't work. There's no point in stopping that. You continue all medications, but you prepare well. The problem is, if you know you'll prepare well, most often than not, it always happens intraoperatively. You have a surprise intraoperatively. So what is the preparation? You need to be, all these gadgets have to be ready. Iris, pupil management devices, adrenaline dilating devices, and dispersive OVD. And apart from all these gadgets, you should follow certain basic surgical principles. The most important is probably the wound construction. You have to be very focused on creating them. Try to have a longer tunnel, try to have a smaller incisions, including the side ports one. Should not be more than 0.9 millimeter, and try to have a long tunnel. Maybe a angled MVR blade with a very small diameter opening, that is should be suppressed. So, and don't try to overfill the chamber with any fluid at any stage of the surgery. Always keep the eyeball soft. And whenever a fluid goes just under the iris a little bit, the iris starts coming out. And once iris starts coming out, it's spoiled. So why dispersive? Dispersive OID in the sense it just keeps the things in position. So this dispersive, I mean, viscoat or viscoat-like substance. Main issue, just watch this wound, it has to be at least 2 millimeter intracorneally. Hydrodissection, this is a step which actually triggers everything. Try to be very miserly in the amount of fluid you induce, just a very little bit amount. So you just enough to get the fluid wave, and then use mechanical ways to break the corticocapsular adhesions. So next would be your fluidics. They do play a role. Try to ensure that your bottle height is not very high. It has to be around 60 centimeters, 70 centimeters. You don't want to have most of the high-end machines. Lower-end machines also will work, but follow these principles. If you decrease the infusion, also decrease your aspiration flow rate and your vacuum to ensure that the chamber equilibrium is not compromised at any stage. Now the type of nucleus division. I would prefer always to have a direct chop, simply because the fluid which is there is always above the iris plane when you're doing the chopping. If you're doing divide and conquer, because the probe has to go within the substance of the nucleus. The fluid will go below the iris, and that causes billowing of the iris. And that's the risk factor for it to come out. So if you're comfortable, better always to stick to the direct chop technique, because at every stage, the holes of the sleeve are above the iris level, so the fluid doesn't have an opportunity to go below. See, now once the division has come out, you can see the pupil has gone down because I had sculpted a bit. So again, use a little bit of dispersive OVT, just place it on the surface of the iris. It just makes the iris behave well. Here I'm using a combination, like first dispersive and little bit of HPMC. But remember, never overfill the chamber. The next water modification is single-handed emulsification. See, I've removed off the second hand itself. The fragments are all divided. There's no role for the second instrument now. If you open the second instrument, the iris starts to trail through that. So just do a single-handed quadrant removal. The second hand comes only for division of the nucleus. Once the division is out, just stick to single-handed technique. And the idea is there is no leakage anywhere else. That ensures that you're not giving an opportunity for the iris to come out to any of the ports. So single-handed quadrant removal would be the best way to deal with the nucleus fragments in this situation. It would take slightly longer time because all your parameters, flow rate are slightly longer, but patience does pay you. And then this is the IOL implantation job. This is an easier part of it. So remember that you don't have to panic. You have to get ready with all these. If you're prepared well to face the intraoperative surprises, let me assure you that things will always go well. So ensure that the wound construction is probably the most critical aspect of it. Don't hesitate to use pupil expansion devices like the BHEX ring in this case. Even if intraoperatively after rexus happens, please don't be afraid to use the device of your choice, BX device or iris hook, whatever it is, but please use them. The advantage is, they put the iris in place and the floppiness can be reduced to a little bit, not every time, but it can help because it maintains the iris tone, pushes it back. And you can see, in spite of using the BX device, still, if you're using a second instrument, the iris still can come through it. But that's the reason why I was referring to that if you can do it with a single hand. But nevertheless, visualization is probably the most important secret for having a good surgery. Ensure that every stage you are seeing well enough. So there are multiple factors which can worsen intraoperative floppiness. High infusion pressure, posterior plane of emulsification, these are the few factors which are going to really worsen it, and leaky wound is probably worse than anything else. So this is my 8-point agenda which I would recommend all of you to just practice. If you know this is a patient is going to develop IFIS, then pre-op atropine, start for 2 days would be better. Incisions are probably more important. Have a perfect long intracorneal tunnel for the main incision. Dispersive OVD, always underfill it, don't overfill it. Very careful hydrodissection with little fluid, and low flow, low pressure surgery. And single-handed technique and anterior plane of emulsification. This should help us to counter most of the thing. There's nothing like one trick is going to work. It's a combination of multiple factors which is going to work. I think with that, I'd like to conclude my presentation. Thank you for attention.
Thank you very much, Dr. Deepak. A good word for you. A good teacher affects eternity. A good teacher affects eternity. You can never tell where his influence stops. This quote is highly applicable for a wonderful teacher like Dr. Deepak Medur. Congratulations.
Thank you, sir.
And the next person here on the podium is Dr. Sudhanshu. I have a word for him. Better than 1,000 days of diligent study. Better than 1,000 days of diligent study is 1 day with a great teacher. You may attend 100 conferences, but if you attend 1 session with Dr. Sudhanshu, you will learn a trick for a lifetime and you will do well.
Thank you for the very, very nice word, which I don't think I deserve, because they are so good teachers sitting here. So we have seen the PCR. Once PCR happened, now what next? If you have managed the PCR, then why should send to the veterinary surgeon? So you should go ahead with your own. If you are not able to manage it, then can send it. So they are what to implant. They are antechamber lenses, which are not recommended nowadays. and then we can have sulcus fixated lenses. Suture posterior chamber intraocular lenses, and without suture secondary implanted, that can be done. Scleral fixated IOL provides more favorable outcome and lower complication rate than AC IOL in complicated cataract cases. So this is case, here we cannot do even the iris claw lens implantation, we cannot do such cases, otherwise we have to do iridoplasty first. So suture transfixation IOL and glued intrascleral haptic fixation IOL, we have the options once we have got the PCR. So this is a demo eye model. So what we are doing, sorry, start demo video. So that demo eye, so scleral fixation 2 millimeter away from the limbus, we have made a incision, a groove, just like we made in the trabeculectomy, and thus just this simple groove, partial thickness, most of us must be doing trabeculectomy. Use a Kesson blade for this, and stop away 1 millimeter from the limbus. And then a blade is on the other side also, and anterior chamber maintenance is introduced, and then made this main incision 2.8 or 2.75, or you can make 3, whatever you are using. And this MVR blade goes from the side, 1 millimeter away from the limbus. And we make the same opening with the MVR blade in the other side also. Because everything is a thought block. We don't want to do the scale, we think it will go bang in the vitreous. So we are suddenly there to take it out from the vitreous. He has paid for it. So don't worry. So you use this forceps to see that it is working, but this space is enough. See from both the sides that this forceps which we have to hold the haptic is working. But there is a space, we have seen that it is okay. There is a space enough that is working. Now I'm making fast forward because we have lack of time. So this is the main important thing. Now you are implanting the lens, and you see when this implanting the lens, forceps has gone inside. Lucky 7 sign means this should first we have tilted toward the forceps, the tip of the cartridge tilted toward so that we can hold it easily. It tilted opposite side, then it will be difficult. So it is tilted towards the side, and then hold it out. This is, you can say 7 size. So we hold. So we have hold it, and once it is out, one haptic is outside eye, still outside eye, so you are not worried that is going inside the vitreous, because one haptic is already outside, you can hold it. And other haptic you are catching with the other side. So one haptic is come, then you put it again from the main season. And this is C sign, which is upright C sign, and you hold it from the other side and keep it out. So no chance of going into the vitreous, because we are holding one haptic at a time. Once it's there, you make a we are making a from this MVR a side opening, and you can insert the haptic inside it on both the sides. And that is, and then you can either glue like this or you can stitch over it. Okay. So this was the demo. We are stitching. इसे भी ओपन करना है. Now this is वेगिया फेकिया. ये आगे बढ़ गया. ज़्यादा नहीं जना. हाँ, okay. So this is a case where suture transscleral fixation has to be done at the at the limbus. We have done the conjunctival cut. We have made a 2 millimeter on the opposite side. We have to make it on the opposite side. Groove has been made. I am just fast forwarding because already shown in the. है तुम्हारा? So, groove has been made. This needle main port has been made. You can see proline has been, tangiroproline has been inserted from one side, taken out from the other side. And then reverse, it is going from the opposite side to the first side. Once the proline has been reversed from the two sides, just pull it out, make a loop, and pass the loop in this eyelet of the lens. Now you are more safe because one of the suture is in your hand, so chances of going in behind is very less. Push it out, and you can suture tight at the wound area. So this is suture. Where we are sticking in the sclera, they are suturing in the same wound. So this is suture, and then I am just perforating it also. Another. This is another case. I am just forwarding what I want to show.
No, go ahead.
So, because we have a next very important topic, so I skip it now. So what we have seen now, the suture was glued interscleral haptic fixated IOL found to be more stable than the sutured IOL. That is UBM guideline, and this is a study in the RP center also done. Take home message, sclerofacial IOL safe and effective, a viable option, especially in eye with low endothelium count. Interscleral haptic fixated more stable than suture transscleral fixated. AC IOL option in elderly patients. Thank you. Now I invite the OPI is not here, but her representative here, Hatamorika, she is speaking on behalf of very good innovation. And this, everyone should have their OT. Previously, we were having IOL cutting scissors in our OTs, but now we have having the ultrasound cutting tip in the OT, which is fixed on the phaco machine, and that can do. We are commonly using, I am using, many of us using. You're welcome.
Thank you very much for a wonderful talk, sir. There is a beautiful phrase from Sherlock Holmes. After solving the most complicated problems, he'll just say, "Elementary, my dear Watson." Yes. So sir is like that. He'll handle the most complicated of cases and just say, "It's very simple, you can also do it." All what you have to do is attend his video-assisted skill transfer courses. So on that note, we will invite the last speaker of this session, Dr.
Miloni.
Dr.
So,
Miloni.
hello,
On
I'm
behalf of Dr.
I'll be talking on behalf of Dr. Neha. Unfortunately, she could not come here due to some unavoidable circumstances. So she has made my work easier. This is her video. So we'll just jump into it directly. It has an audio also. Sure.
Stop cutting, start slicing. This is the way the tip just slices through IOLs, just the way a tailor cuts through a taut cloth. The jaws of the tip do not open and close like a scissor. This is an opacified IOL which is being cut into 4 slivers, so a 6 mm IOL can be removed through a 2.2 mm opening without extension. Here we do not even need to put an IOL scaffold below, as the jaws do not open and close, thereby protecting the endothelium and the posterior capsule. This is another lens of lens pitting, where the lens is trisected and therefore removed through a 2.2 mm incision once again. Between each step, viscoelastic has to be injected so as to protect the endothelium. And on day 1, we see all patients with 6x6 vision and crystal clear corneas. This is a 32 diopter lens, very thick, hypermetropic patient with very shallow AC. The only way out would have been to extend the incision and create a lot of astigmatism. Here the lens was bisected at the optic, and the optic haptic junction was also cut and thereby removed through a 3 mm incision. The older methods to remove IOLs were either extending the incision or the twist and out technique, which is a very nice technique. However, the surgeon has to be skilled and very quick in doing the procedure. Also, sometimes in case of a posterior capsular rent, it is not advised. The oldest fashion is to bisect the lens with scissors into 2 parts and then remove it through a 3.2 mm incision. However, this leads to striate keratitis, corneal edema, and sometimes even Descemet's detachment on the second day. The tip is just like a phaco tip, but it is a solid metal tip made of titanium. One has to prime the phaco probe with the normal tip as usual. Then remove the normal tip and then attach the IOL slicing tip on it. These are the forceps which help in holding the IOL through the side port. They are ergonomically designed. So once we've held the IOL, all one has to do is just press on the foot pedal, and it smartly uses the ultrasonic power of the phaco machine and the phaco probe to slice the IOL. Temperatures were checked at the tip of the IOL slicing tip and the tip of the phaco tip. Both were equivalent in temperature. The phaco power is kept at 30% power. There is no vacuum or aspiration as the tip is a solid metal tip. Good counter pressure has to be given as it's not a hollow tip and doesn't have any suction. How a piece of plastic is cut with a knife is shown here. However, if the knife has an ultrasonic vibration, it can even cut a piece of hard plastic. There are different tips for different phaco machines as the lengths of all differ. When will you need this? The lens just shoots through the cartridge and creates a posterior capsular rent, or a trailing haptic gets broken at the time of injection, or a leading haptic. You never know when you will need it. Broken haptic complications, opacified IOLs, bag lens complex being dislocated or subluxated, trifocal lenses not being tolerated, a refractive surprise which we will see more and more in our post-LASIK cases. This can be kept aside or ETO'd and put aside just like a vitrectomy cutter. We keep a lens slicer. This is so smooth like butter that within 1 to 2 seconds the lens is cut. One method over here I am using where I have used an IOL scaffold. This was a patient intolerant to the trifocal lens. It was a toric lens, as you can see, but in spite of all that, one has been able to cut the lens easily into 4 pieces. These are very tricky situations. Here I have used a scaffold to protect the posterior capsule in case of chamber fluctuation. However, sometimes we have an open posterior capsule also. You can see the new toric lens being implanted so well. This is a patient who had a YAG laser done. So first I had to cut the IOL, or rather slice the IOL into 3 parts, and then I have implanted a 3-piece in the sulcus. The other use of this tip is taming the hard cataract. One has to do just the way one does a horizontal chop. The only difference here is that in the horizontal chop, the phaco probe or the phaco tip is holding the cataract with a vacuum with your right hand in a right-handed person, and the left hand is going around the equator and pulling the chopper towards the center. Here we are stabilizing the cataract with a stabilizer which has a ball tip and keeping the left hand steady, and then with the right hand using the same tip to cut through the hard cataract. Here we can see the first chop was made like a chopper, therefore it has fluffy white edges. But now, as you see, when the next chop is going to be made, I will be pressing on the foot pedal, and because of that this chop is very smooth and has clean borders or clean edges. One has to become familiar with doing the horizontal chop and having the confidence to go around the equator to stabilize the nucleus. One can first practice doing the horizontal chop on soft cataracts and then doing it on hard cataracts. Here, this is to demonstrate how chewy the cataract and leathery the cataract was. Thank you so much, Dr. Neha Dholakia.
Dr. Meloni, one thing, are you using?
I have fortunately not required.
Actually,
I have not,
we are
but
using it, but problem is only coming in when we are inserting this sleeve over it. That got
Yeah, it cuts the sleeve.
so
It cuts the sleeve.
It cuts the sleeve. So we have to make 2 or 3 sleeve waist sometime.
Okay.
But what this phaco, this is not for oil cutting. If you go for the phaco cutting, then you have to increase the power. The 30 power is not going to.
See, one thing I've noticed, Shantu, I've done a lot of cases. I've done a lot of initial trials for Neha, and I also have done a lot of design modifications in what you're
Correct,
using
correct.
now.
I know, she mentioned.
Beyond 40 to 50 phaco power, nothing changes. I've cut some of the videos you saw, 32
Correct,
diopters. I've cut
correct.
Envistas. So, you can take the power to 100, the cutting doesn't change. The only thing it does is just causes little heat. So I've just told Neha that you
30
tell
to
everybody to
40,
not go
yeah.
beyond 40, 50, because I've tried to
That's-
cut the lens even outside under the
That's
microscope
true.
with 40
But problem
power
is
or
only
60
coming
or
in,
80.
in
It cuts
coming.
the same.
Problem is coming only when we are sleeve is cutting many times, because we are not doing it. Our staff is doing it. So it is an issue that we have to solve it. But this is a definitely very good innovation, and is going to change. But till you are using it, I will request each and everyone to have in the OT that I have requested for last 10 years, one IOL cutting for Caesar. That is 5,000, 6,000 rupees available everywhere. Everyone should have the IOL cutting Caesar. You should not leave inside the broken haptic IOL. Previously we used to do it. टूटा हुआ हैप्टिक छोड़ दिया पेशेंट
I
डिसलोकेट
think
है
all
द
of us
पेशेंट
are
विल गो टू
guilty
अदर सर्जन
about it.
वो कहेगा टूटा हुआ लैंड डाल दिया तुमसे पैसे पूरे ले लिए हैं देन यू विल बी इन द ट्रबल सो आई ऑलवेज ट्राई टू टेक इट आउट by either any way, either in that incision, take it out by SACS or by cutting the forceps, or there are many methods. But because I was speaking on this topic for last 7-8 years, but this time I thought she has got a very good innovation, so she should speak on it. So I skipped the IOL exchange.
Okay,
So-
so one little point here. Neha, when we were initially working on this, was always saying make 3 slices. But over time, last 4 cases I've done, because see, I have an institute, I have 60 surgeons working with me. So these things keep happening. Sometimes the haptic is stuck or broken or something. So the trick is you can do it in 2 splices. The only trick I found is start from where your haptic just touches the optic. Hold that part and go straight to the opposite haptic. You have beautiful 2 splices will come out of 2.8.
Same thing we are doing the Caesar also. We are holding at the optic junction and we are
Don't
cutting
cut
from the
somewhere in
center.
the center, because it looks cosmetically more appealing to have the haptic in your hand and cut from here. No, then you will have to make 3 splices. But if you rotate the haptic so that your optic haptic junction is now at your wound, now you go. You will have a straight linear cut, and just in 2 splices you can take the thing out of 2.8.
Second thing, important point to remember, you have to hold from the side port the lens.
Yes.
That will motor
Yeah, so
better
there has
control.
to
You
be
have
a
to hold
good
from the side port,
counter
and then you cut whether Caesar or whether diagonal.
Kamal,
Thank you very
any-
much, everyone,
Dr.
because we have.
Any complication possible?
No, you see, there were some issues. I'm sure you must be aware. There have been changes made into the
Correct.
splicing angle and the bevel thickness, because this is what I recommended, Neha.
Yeah.
In case of hypermetropic eyes, you can be in trouble because you're working in the interior chamber. So the 2D appreciation of the depth of the endothelium is little tricky. So this patient where I cut the 32 diopters, my heart was here because the chamber was very, very shallow. The opacified lens which you saw,
Your heart was always in the wrong place. Now,
So
doctor,
do you use viscoelastic?
We have
make
spent our time, sir.
which
That's
company-
basic.
Not the
It's
irrigation.
Ushma, and we have a
yes,
stall
yes.
here.
Cohesive viscoelastic
We
down
have a
there.
stall here. Ushma is the company, and you can order the tip from IOL-cutting.in, IOLcutter.in.
You can
And the stall is here at P5.
Okay, how much is it?
Then you find the,
1-3.
you can find Nehra Dolakia, then you find the place from it.
Thank you. Thank you all for a nice houseful show.